Hi, I'm Chris, and I'm here to talk a little bit about quality indicators, or actually a quality indicator in colonoscopy. And I wanted to start by asking a question: who performed your colonoscopy? Um, Maybe you didn't have a colonoscopy. Maybe your mother or father has had a colonoscopy. Who performed their colonoscopy? And more importantly, how do you know that that physician is actually good at colonoscopy? Um, I think a lot of us that are watching this presentation probably have a good idea of whether or not the physician that scoped them is a good colonoscopist. They've probably worked with them, or yeah, you've seen them identify 1 millimeter polyps or these tiny polyps, or you've worked with them long enough to know that their complication rates are relatively low. So you have a pretty good idea, but the vast majority of patients that are coming in to be scoped really don't have an idea, other than they know that they're going to a highly trained, qualified physician. And if you ask them, they would probably say something like, well, my physician has scoped for 10, 15 years, so I'm sure that they're good at colonoscopy, which is not always correct. We have an enormous amount of literature that has shown us evidence that physicians are missing adenomas during colonoscopy. Some colonoscopists missing as many as 26% adenomas. One study even showing that colonoscopists have missed advanced adenomas at a rate of 5.4%. Other studies have shown that post-colonoscopy cancers are attributable to those missed adenomas and lesions. And that's relatively intuitive, right? Like if you're missing these adenomas, then those adenomas have the propensity to turn into a adenocarcinoma, or a malignancy, and that would be colorectal cancer. And we've seen in studies that about 6% of all patients with colorectal cancer have had interval cancers. And then finally, we have a lot of data that shows that there's variation in the detection of adenomas by endoscopists. What does that mean? It's pretty simple. It means that different colonoscopists are better at finding adenomas than other endoscopists. So we know that the answer to the question is that it does matter who's performing your colonoscopy, and that there is a degree of variance in who is performing that procedure. Which is really interesting that the majority of us don't know if our physicians, the majority of patients don't know if our physicians are good at colonoscopy, when we have relatively meaningless games, and we have a bunch of data that can explain who is good at their jobs, such as Patrick Mahomes here, former Texas Tech Red Raider. He's good at his position at being a quarterback. We have a number of metrics or quality indicators, or indicators of his performance being good. He's 38-8 as a starter, 108.2 passer rating, 82.9 QBR. We have some more advanced metrics such as 8.33 adjusted net yards per pass attempt. All of those show him being tops in the NFL, or in the top 5 in a meaningless game. When I Google searched this, I think I found like 46 different metrics, and I didn't even really look that hard. So there's all kinds of data to show us about a meaningless game, which I love, by the way. Here is the gross domestic product. This is an indicator. This is the gross domestic product of the US, an indicator of economic health. Maybe you're choosing a stock. We have price to earnings ratio and a slew of other data that shows us which stock to put our money into. Maybe you're looking at buying a new house and you have kids. You're probably going to want to look at what the grades of schools are in the area prior to buying a house. So in all these industries, we have a variety of metrics that indicate performance. And in healthcare, the metrics that indicate performance are referred to as quality indicators. So what is a good quality indicator for colonoscopy? That the answer to that question is adenoma detection rate. And it's considered by and large to be the most meaningful quality indicator that we have. It is considered the primary measure of quality of inspection, and the single most important quality measure in colonoscopy. What is an adenoma detection rate? It is simply the number of patients in which one or more adenoma is discovered during initial screening colonoscopy, divided by the total number of patients undergoing initial screening colonoscopy for patients age 50 and up. So if we have 10 patients age 50 and up, they come in, they're asymptomatic, and they're coming in for their first screening colonoscopy. They're all included in the study. And let's say we find at least one adenoma in 4 of those patients, the adenoma detection rate for that population of 10 would be 40%. The next question is, what is an acceptable ADR? And an expert panel has determined that the recommended rate for adenoma detection should be 30% or higher for men and 20% or higher for women. Note here that that is a recommendation. It is not based on an average. That same expert panel concluded that colonoscopists with low ADRs fail to identify patients with precancerous lesions and find fewer patients with multiple lesions, and that puts patients at risk for cancer. Failing to find the precancerous lesions leads to the colonoscopist recommending inappropriately long intervals between examinations. So what does that mean? It means that if the colonoscopist isn't finding any adenomas, of course, their next colonoscopy, their interval colonoscopy, isn't recommended for 10 years, versus if they had found an adenoma, you're looking at somewhere between 3 and 5 years, depending on the type of adenoma. So if that patient, if they are missing an adenoma and not recommending another colonoscopy for 10 years, then that adenoma has the potential to turn into an adenocarcinoma. That interaction emphasizes the essential nature of knowing the adenoma detection rate of individual colonoscopists in order to ensure adequate patient protection. So what is the significance of this metric? We know that 145,000, we have 145,000 new diagnoses of colorectal cancer annually in the US alone, and it's estimated that 53,200 people died of colorectal cancer in 2020. Comparatively, 38,000 people died of automobile accidents per year in the US, so we know it's a substantial public health problem. We've already established that adenomas can transform over time to become an adenocarcinoma. So that general and intuitive idea, once again, is that endoscopists finding adenomas prevents those adenomas from becoming malignant. Then the question becomes, what is that relationship? Do we have data that shows us how often those adenomas turn into cancer, and what does that mean? How does that translate to mortality? And luckily enough, we have some great work that's been done fairly recently in 2014 by Corley, who presented the association of adenoma detection rate in 314,000 colonoscopies by 136 gastroenterologists. So huge sample. And they followed these patients over a 10-year period until they had another colonoscopy, or they left the healthcare system, or they were diagnosed with colorectal cancer or died of colorectal cancer. And what they found was pretty astounding. They found a 5% reduction in cancer mortality for every 1% increase in adenoma detection rate. So again, it's kind of intuitive. Finding the adenomas prevents people from dying of colorectal cancer, right? But the study kind of brought it to a head of what exactly that relationship is, and 5% reduction in cancer mortality for every 1% increase in ADR is very significant. The study showed that physicians with an ADR of greater than 33.5% left their patients with 1/2 the risk of colorectal cancer as physicians with a ADR of less than 19%. So we know the significance of the metric and how it relates to colorectal cancer and mortality. How else can our practices use adenoma detection rates? We've used it at my organization as an external benchmarking process or metric. We've benchmarked. What that means is we benchmarked with other organizations. We've shown them our group ADR and compared it with their group's ADR. In fact, one of the uses that we've seen, that a good story to illustrate the use of ADR is one of the organizations that we benchmarked with, like way back in 2011, when it was a relatively new concept to track this metric. I spoke with a nurse at a different organization who said that their organization began tracking ADR and was able to show one of the physicians that his substandard rate of ADR suggested that he probably needed glasses. This physician had gotten was getting a little older, and they used ADR to convince him he needed to start wearing glasses during procedures. And surprise, surprise, his adenoma detection rate in males increased over 15% after wearing glasses. So pretty significant results there. We've seen an ADR used as an internal benchmarking tool. Some organizations are reviewing it at their executive committee meetings, and they have potential consequences for repetitive substandard rates. At our centers, repetitive substandard rates of ADR could mean that a physician loses operating room time. We've also seen ADR a bunch in recent literature. It was used recently as evidence for lowering the age of screening colonoscopies to 45. So very significant there. Adenoma detection rates have been cited as evidence of effective alternative bowel preparation, such as colon irrigation prep, i.e. Hygia care. ADR has been used to show how increasing withdrawal times can increase the effectiveness of colonoscopy. ADR has been used to show how AI is effective during colonoscopy. Our practice is going to use, or has used, ADR in order to evaluate new and updated video technology, and we will soon be using it as a tool to evaluate the 45 to 50 demographic as we continue to get more and more patients in that demographic coming in for screening colonoscopy. We're going to compare that with the age 50 and up, just to gain a better understanding of that demographic. So one of the other applications of ADR is we've kind of seen it morph into other projects such as sessile serrated polyp detection rates. The understanding of such polyps has changed greatly over the course of the past few decades. Such lesions were once considered benign, non-neoplastic colorectal polyps, contrasting to the conventional adenomas, whereas now, based on recent literature by Crockett, we know that serrated pathway cancers are thought to be responsible for up to 35% of colorectal cancer cases, which makes that subtype a substantial public health problem with an incidence potentially greater than that of pancreatic, gastric, or esophageal cancer. So what should our sessile serrated polyp detection rate be? We don't have a lot of literature yet to show us where we should be at in terms of the percentage of that rate, but we did have a 2017 study come out in gastrointestinal endoscopy that showed in 46,000 colonoscopies by 77 endoscopists an SSPDR of 6.8% via Anderson et al. 2017. One large group was kind enough to share their data with us, and I'd like to kind of break down what we see here. This is the adenoma detection rate tracked. Male is in blue and pink is in female over the past 13 years for this large group that does over 20,000 colonoscopies per year. And right off the bat, you see how much it's improved over the course of 13 years. And the question is, how does that happen? This group attributes it to a number of factors. One, of course, the technology has gotten better, imaging has gotten better. We're able to see smaller polyps during colonoscopy. We've seen how much technology has improved with our iPhones in the course of 13 years, and that goes for colonoscopy as well. Another, we know that withdrawal times and increasing withdrawal times can also increase the effectiveness of colonoscopy in terms of ADR. This group tracks their average withdrawal time, and you can see here how similar the charts are in terms of the withdrawal time increasing from 8 minutes to an average of 11 minutes in 2020. So a full 3 minutes. And we see like how that translates with ADR. Certainly some of it is attributable to that. This group also believes that there's kind of a competitive aspect to tracking this data, and this group tracks individual MDs ADR as well, and they show it at group meetings. So these physicians are able to see each other's ADRs, and some of them began to get competitive about it. which is human nature. So they believe that that competitiveness kind of also led to some increase in adenoma detection rate. Finally, this group believes that the sessile serrated polyp detection rate increasing pretty dramatically from 6% to 10 to 11% in 2020 also causes these numbers to go up too, because these the adenoma detection rate includes the sessile polyp detection rate. So doubling the sessile polyp detection rate also increases the adenoma to those levels of 55% and 39% in females. And then also, I think it's important to kind of go back to that study that I highlighted before that shows a 5% decrease in cancer mortality for every 1% increase in adenoma detection rate, and kind of think about what the implications are here when there's a 22% increase in males and a 18% increase in females, and kind of what that means for patient outcomes. Criticisms and limitations. So we're not doing it justice if we're not also discussing the criticisms and limitations of the metric. One of the most common criticisms that I hear, and it's a misconception, is that 30% and 20% are the national average, and this data is way higher than that, so it can't be correct. Meaning, this physician's adenoma detection rate is 55%. That can't be correct because the national average is 30%. First of all, it's not a national average. There is no national average. It is only a recommendation of an expert panel, and that same expert panel that made that recommendation acknowledges that they may have set a low bar. If we had a national average for ADR for physicians specializing in endoscopy, I would assume it to be above 40% for males and 30% for females, based on some data that we have, including a 2-year benchmarking study in 2016, which showed 135 endoscopists ADR and about 161,000 patients. And that study showed an average of 46% in males and 33% in women. And then I have a quote that I found that I like from another study that actually said that recent evidence shows that ADR benchmarks are inappropriately low. Another criticism that we hear is that it can be gamed. Physicians game it, and that's how they get to these high ADRs of 50, 60%. Internally, we performed a 6-month audit on about 35 physicians that showed some discrepancies, but the data showed a difference of less than 3% for all physicians audited, and one physician's ADR actually improved. Contrastingly, a 2017 study concluded that it can be gamed by including diagnostic indications that don't belong in the study, meaning that patients with symptoms were get included in the study in order to game it, and that one physician increased their ADR by 6.7%. What does that mean for centers that want to conduct an ADR study or are conducting an ADR study? We need to educate nurse staff on which patients are supposed to be included in the adenoma detection rate study, and also educate nurse staff on the importance of the metric, why we're tracking it. And finally, we want to give them control over who is getting in the study and who is not. And periodically, we want to audit the study to ensure the legitimacy of results if we want to have a legitimate study. We track adenoma detection rate because it is evidence of quality care in colonoscopy. And that data enables us to make informed decisions about physicians, about our physicians and our processes or equipment, and whether or not they are effective in colonoscopy. It all goes back to the original question of who performed your colonoscopy, or who is scoping your mother, and can you say that they are definitively good at colonoscopy? And you cannot if you have no idea what their adenoma detection rate is. If you're wondering where to begin in conducting a study, ask your director, first of all, if you are already. If not, you should discuss with physicians. Physician buy-in will be imperative to get a real meaningful study going. Make sure to follow up on it, ask how you can help or be involved. And if you have any questions, feel free to email myself. I have some tools such as a flow chart that we developed to help nurse staff determine who belongs in the study and who does not. But thank you for your time, and I look forward to hearing from anyone that is interested in following up. Thank you.